Okay, we'll get started. Thank you again for joining us, everyone. Today, I'm really excited to hear from Dr. Geoff Tison, who is Assistant Professor in the Department of Medicine and Division of Cardiology here at UCSF. Dr. Tison is also faculty in the Bakar Computational Health Sciences Institute. He completed his cardiology fellowship training as well as advanced echocardiography and preventive cardiology training at UCSF, and served as the first UCSF Digital Cardiology Fellow. Dr. Tison leads a computationally focused lab that employs machine learning and statistical and epidemiologic tools to achieve cardiovascular disease detection, phenotyping, and prevention. He has multiple active grants dedicated to work in heart failure, including investigating heart failure, racial and ethnic disparities in pooled NHLBI cohorts, machine learning and mitral valve prolapse and sudden cardiac death, and dynamic prediction models in heart failure using machine learning and real-time data. Dr. Tison has led and participated in various clinical studies, including the multi-ethnic study of atherosclerosis, the Women's Health Initiative, and the UCSF Eureka Health eHeart study. So really excited to hear your talk. As a reminder for the audience, if you have any questions, please feel free to put them in the chat, or you can raise your hand and we can have you ask your question in person virtually. So with that, I give it to you, Dr. Tison.
Great. Thank you very much, Joyce, for that kind introduction. And it really is my pleasure to be here today to speak at Grand Rounds. As I was preparing my talk, I was just reflecting on the fact that I gave Grand Rounds here almost exactly 5 years ago to the week. And at the time, I spoke broadly on my excitement and potential that I saw for the topic of AI in medicine. In that talk, I spoke a lot about the methods themselves, distinguishing them, how they differed from traditional statistical, biostatistical techniques that many of us are familiar with, and that was my own research foundation. And I focused on that in part at the time because there were really only a handful of examples of applying AI machine learning to medicine back then, 5 years ago. Now, in the intervening time, in the intervening 5 years, there really has been quite a bit of development in the field. This is work, of course, done by many groups around the world, including some work from my group. And I would say that, at least in my corner of the world, there really has only been increasing excitement and enthusiasm for the impact that AI and machine learning might have. The promise certainly hasn't waned. That's not to say that there hasn't been a leveling off of the hype curve, so to speak. Certainly there was, and perhaps still is, a good amount of hype that's circulating around machine learning and AI. But I think for most of us who are, day-to-day, boots on the ground, deploying and working with these methods, there really has been a steady stream of evidence, both from our own work as well as work in the literature, that a few things, that AI offers a unique set of tools and capabilities that previously were not possible, that it's here to stay, it's not going anywhere, it's not a passing fad, and that AI can help us expand to think about what is possible to do with data in medicine. And so that's where I'd like to focus my talk on today. And here are my disclosures. So I've organized my talk into 3 main themes as listed here. And I will be discussing work from my lab over the past few years. But I will be trying to use these themes to focus on different aspects of each individual example that I do discuss. Just as a warning, I will be jumping back and forth between a few different studies as relates to the themes, focusing on different aspects as pertains to the themes. So the first one is really the most accessible and kind of obvious, perhaps central advantage that AI and machine learning provides. And that is its ability to work with and distill large amounts of raw data. So this is data that typically had been otherwise intractable or very high dimensional, such that prior analytic techniques or methods couldn't really deal with it. We had to reduce it down into something more tractable and thereby process it. So AI offers the ability to work with, in most cases, the raw formats or near raw formats of data. Therefore, for the right task, for the right application, it can then be applied for disease detection, disease phenotyping, prediction of future outcomes, automation of tasks like measurements or other tasks that typically have required human input. And so this is really one of the core advantages that machine learning and AI tools offer beyond what we could do before. And I'll give a number of examples in this theme. The second theme is that it's certainly in its best sort of version, in its best version of itself, machine learning and AI can allow us to do more with less. And there are a number of arenas in which this has been shown to be true. But the most sort of simple, accessible example might be being able to take data from a diagnostic test that is less invasive, less costly, perhaps less risky to the patient, and draw a conclusion or inference from it far beyond what can typically be done with that type of data. So perhaps drawing a conclusion akin to what one might draw from a more expensive, more risky, more invasive type of data. And there are variations on this theme, but and it's not always going to be true, but AI offers the possibility to consider doing things like this. And so this is, I'll give some examples of ways in which we have seen this to be the case. And the third example extends really from the first core theme, and that is by virtue of the fact that machine learning and AI allows us to work with, in many cases, the raw formats of the data in large scale, we can then begin to use AI and machine learning to uncover patterns that may relate to physiology and mechanism in a data-driven manner. So looking at records, thousands, hundreds of thousands, millions at a time, and finding patterns in that data, in the raw data, in fact, that otherwise would have gone unseen, are perhaps even unseeable to the human eye, and certainly with that much repetition, is sort of intractable for any human to look at. So the ability to begin to uncover patterns that may relate to physiology and mechanism. This is enabled by a group of methods called AI explainability techniques. That is a pretty hot field within machine learning itself, within machine learning research itself, being applied across domains, not just medicine, of course. But I highlight it here in part because there's such a tight linkage between biology, physiology, disease, and the signal that we're capturing in many of our diagnostic tests. Because of that tight linkage, AI explainability becomes that much more important when applied in medicine. And so this is the third theme that I'll begin to give some examples in. But this, as I mentioned, this is really an active area of research, and there's still a lot to do with this in this third theme. So I'll start by giving a little bit of an intro into this first theme, in part because so much extends from it. So it's no surprise to everyone here, certainly, that there's many different sources of data in medicine. Of course, there's data in electronic health records, so this includes the notes, discharge summaries, medication lists, labs, procedure notes, et cetera. And all that is very important for clinical care. And then, of course, there's almost another category of data, some of which are shown here, which are sort of raw diagnostic test data. So things like ECGs, echocardiograms, ultrasounds, nuclear medicine studies, radiology studies, CT scans, et cetera. And increasingly, there's longitudinal formats of a lot of this data, like Zio monitors that are currently measuring 2 weeks of data, right? But next year might be 2 months of data. And then, of course, even data from smartphones, from Apple Watches, from Fitbits, from home blood pressure monitors, where your patient's bringing in their blood pressure scrawled on a coffee-stained notepad with the date, hopefully. Increasingly, there is a large amount of data that doctors are really kind of put at the center of, right? Doctors are expected to some degree to integrate the data, not only from the clinical record that we kind of hold true and can hang on to tightly, but also data from home tests, remote sensing. Maybe they got a genetic test from a consumer company and they bring it to us and ask what to do with it, right? So increasingly, physicians are put at the center of all this and expected to make sense of it. in short order. And so to some degree, it almost feels like physicians are being asked to function as databases or computers, processing a whole lot of different kinds of information and hopefully distilling it for their patients so they can make recommendations and suggestions to the patient. And as technology is ever expanding with developments in genetics, proteomics, microbiome, increasingly there's a number of, there's almost an ever expanding amount of data that we're expected to deal with. Of course, with digital health, there's sort of remote handheld ultrasound, remote ECG. And so there can be this feeling that as technology will continue to progress, there will be an ever expanding amount of data that we're going to have to deal with. And so part of the vision of this first theme of how one of the benefits that AI can offer relates to this. So it's the hope that, again, in the best case scenario, machine learning and AI tools can help us begin to sift through these large amounts of data and provide value, hopefully provide meaningful insights that improve the situation, don't add to the burden. And I think this is what I'm talking about when I mentioned that over the past 5 years, there has been an increasing amount of evidence for those of us, I think, in the field to show that proof of concept is being shown to be true. We can build these tools. These tools can make predictions that are valuable. I think the last part of the pipeline of demonstration of clinical evidence of clinical value is, still in its early stages. There have been a number of randomized clinical trials that are starting to come out, but as everyone knows, that takes time. But I think this is the last sort of leg of the journey that we're going to start to be seeing progress in over the next 5 years or so. But for those of us that are in the field, I think the earlier parts of the journey have shown that indeed there is promise for machine learning and AI to help us do this. So what are these machine learning and AI tools? Well, I actually drew this slide from my grand rounds 5 years ago. I'm not going to go into too much detail here in terms of the different methods, but suffice it to say that when most people talk about artificial intelligence, AI, they're referring to machine learning algorithms, which is really an umbrella term that refers to a number of different categories of algorithms, some of which are listed here. And they, by and large, provide the ability to process data in ways complementary to traditional statistical approaches. So they effectively expand our tool belt, allowing us to process data in different ways, not always with any advantage over traditional techniques, but in certain cases, for certain tasks, they do indeed provide distinct advantages. And so to drive home one of the ways in which, from this perspective, AI and ML approaches differs from traditional statistical techniques, I'd like to draw an analogy. And this is actually a real world analogy that I think hopefully will resonate with most people here, and also is indeed a way in which statistics is applied as well as versus AI is applied to this kind of data. So going back to these types of raw data formats that I showed earlier, everyone here is familiar with the fact that there essentially are two types of data related to each one of these studies, right? So for the electrocardiogram, we have the raw 12-lead ECG or the raw telemetry strip, right, on the monitor in the wards. And we have the 4-line diagnosis made by GE Muse that is then confirmed by cardiologists. We have the sort of summary report, as well as all the metrics, the QRS duration, the PR interval, et cetera. So these are the derived reports and summary metrics from the raw data itself. Similarly, for echo, we have the echocardiogram, which comprises of almost 100 or 120 videos from the ultrasound that it exists in its raw data format. And then once an echocardiographer interprets all that information, can distill it into a report that contains measurements of left ventricular volume, left atrial volume, degree of aortic stenosis, degree of MR, that those derived measurements are very valuable. Those derived measurements can point towards abnormalities, help us diagnose disease, and so contain a lot of valuable information. Now, traditional statistical approaches, when dealing with this type of data in particular, essentially there was no way for those approaches to deal with the raw formats of the data. There was simply no way to put in a video of an echocardiogram into a traditional logistic regression model and expect it to do anything. So what statistical approaches acted on instead were the derived measurements. So things like left ventricular volume, ejection fraction, et cetera, those derived metrics could then be put into a traditional statistical technique and used for certain prediction tasks, for certain diagnostic tasks. And that's kind of where the field was until the explosion of machine learning about 10 years ago. Now, on the other side of the coin, as valuable as those derived metrics are for certain types of disease prediction, there's a lot of data that's left on the table, right? Compared to the raw data itself, we own the measurements contain a lot of information, but only contain information for the things that we know to measure or the things that we know to look for. In the case of the ECG, we're familiar with the different features, P wave, QT interval, et cetera, but there may be features that we're unaware of to measure, and those are not going to be captured in any derived measurement. And so in contrast to statistical methods that work on that can really only handle the derived measurements, one of the main advantages, which is this first theme of AI, is the ability to work with raw formats or near raw formats of the data. And thereby, in addition to hopefully identifying similar things that can be done with the derived metrics, like volumes, like EF, can also potentially find new features, new associations, especially when we're working with hundreds of thousands or million scales of data, right? So in addition to just sort of replicating tasks with algorithms that already exist, there is the added potential, not promise, but potential to go beyond that and potentially find new associations and new tasks that can be done with existing data. So that sort of encompasses the promise of AI applied to medicine. And certainly as data, we're increasingly getting longitudinal formats of data with Zio monitors, et cetera, then this, especially with remote sensors, as many of you probably have patients bringing in data from their Apple Watches, the scale of data rapidly increases. And so I think the advantages or benefits that machine learning has to distill this information might be very welcome. And so with that, I will dive into a few examples of this first theme here of ways in which we have used AI to distill large amounts of raw data. So the first study I'll talk about is this, which was published almost over 4 years ago now. This was done in collaboration with the Healthy Heart team, as well as Greg Marcus. And here, what we wanted to do was see whether we could take raw data from an Apple Watch, which at the time did not have the ECG monitoring on the Apple Watch, just take the heart rate measurements, the raw heart rate measurements, as well as the accelerometer measurements, and determine whether we could identify those with and without atrial fibrillation. Now, the heart rate measurements, for example, the raw data is illustrated here, where these are measurements every 5 seconds or every 5 minutes, depending on the setting of the watch. Similarly for the accelerometer, which varies. And so in order to train this model, we took data from the Healthy Heart study, from Apple Watches, as well as from a live course from people around the world. And we're able to, what we wanted to do was take the raw data and determine whether people had AFib. Now, in dealing with this raw data, as I mentioned, each person would have hundreds of thousands of heart rate measurements similar to this. So the traditional approach might have been to take derived summary metrics of this data, so the mean, median, mode, measures of variance, perhaps doing this on a daily measurement scale, doing this on a weekly scale, monthly scale, deriving summary metrics, and then running some kind of regression on it to see whether we could discriminate AFib from not. The alternative was to take the raw data and train a neural network that could process all of that sort of in its native format and do a similar discrimination. So we ultimately went with the second option here, trained a neural network, and then validated it in a number of patients coming in for cardioversion at UCSF. So here we had patients who were getting cardioverted and had 12 lead ECGs before and after with AFib and normal sinus rhythm, confirmed by electrophysiologist. And against this gold standard, our algorithm did quite well with an AUC of 0.97 to discriminate those with AFib. We also did have degradation, or we also examined this in an ambulatory cohort, and there was degradation of performance. But this, happy to talk about more about this in detail offline, but there was a lot of noise in this cohort with noisy labels. And so at the end of the day, we actually interpreted this as actually a positive signal, even though there was degradation. So this was one of the first demonstrations of applying AI in this way to help us process large amounts of raw data, hundreds of thousands of data points per person, to provide a clinically actionable prediction. And as many of you probably are aware, there have been subsequent validation of the Apple Heart study, et cetera, which kind of had its own issues. But at the end of the day, this idea, this concept has been demonstrated again since. So the second study I'll talk about also used data from a remote sensor. This is a Zeo monitor that almost everyone here should be familiar with. And as you know, it records up to 2 weeks of a single lead ECG data. And we wanted to see whether we could train a neural network in an end-to-end manner, meaning when I say end-to-end, I mean it accepts the raw waveform of the ECG as an input and directly makes a prediction of one of these 12 rhythms as the output. Now, this is an example where we're essentially, this was published in 2019 and kind of one of the first applications of neural networks for this data in this way. And this is an example of us predicting tasks that we already had algorithms to do. And so you might wonder, why this is valuable. But for us in the field as a demonstration, this was, one of the first demonstrations to do so. And if this could be done, we then understood that we could take this sort of setup and try to predict not only these tasks, but additional tasks and potentially novel ones beyond what we have current algorithms to do. So that was ultimately the intrinsic promise of trying to show this. So we showed this for 12 different rhythms. The AUC was quite high for all of the arrhythmias. We had a consensus committee of 9 electrophysiologists and cardiologists who overread a consensus data set of ECGs. And we then were able to compare the individual cardiologists, their individual read against that consensus, as well as the algorithm against that consensus. And these are just a few examples shown here, but for these classes, the algorithm is the blue, and the closer up to 1 is better performance. And so with only rare exceptions, the algorithm essentially performed as well, if not a bit better than individual cardiologists. And the green dot is the average cardiologist. Of course, there was variation by class. Now, one of the more interesting findings from this study, I would say, is this, which is that the mistakes that the neural network made, which is here on the left, mirrored the mistakes that an individual cardiologist made on the ECG. And there's a number of reasons why this might be true, but I think at the end of the day, I think the algorithm is not only it is training from individual human insights, but ultimately it learns patterns that are quite similar, and so it's intriguing that the mistakes it makes reflect those that humans make, and this has been shown elsewhere. So we took that sort of concept and then extended it to the standard 12-lead ECG data here at UCSF, actually. And extended the number of diagnostic classes from 12 to 38. So this now expanded beyond simply rhythm. We also looked at conduction, chamber enlargement, infarct, as well as other diagnoses. So 5 different categories of diagnoses using 12-lead ECGs as the input. And in a similar manner, here we also had a consensus committee made up of Byron Lee, Henry Shaw, and Tomas Walters from EP, who painstakingly manually reviewed a consensus committee of ECGs for us. And we then were able to compare our trained algorithm, a single algorithm, which diagnosed 38 different classes, different arrhythmias, against the cardiologist overread. So this is everyone here, really. This is the ECG confirmations that we cardiologists here at UCSF make on top of the Muse diagnosis. And then we also got the raw unedited Muse diagnosis for this data set. And so we were able to compare all 3 of these performance really against the consensus committee. of the three EPs. And so by and large, this is aggregated by category. So arrhythmias, conduction, chamber, infarct, et cetera. By and large, you can see that the cardiologist confirmation agreed more with the consensus committee than the raw muse, the unedited muse, for each one of the categories. And then also that the neural network was at least as good as, if not perhaps in some cases, slightly better than, agreed more with the consensus committee than the individual cardiologist did. And so that's this chart here on the left. On the right, we fixed the specificity of the neural network at the specificity of the cardiologist on average. So that's shown here. And then we examined the sensitivity for the given class. And again, we saw at least similar performance by the neural network compared to an individual cardiologist. And then similarly to the prior graph I showed in the prior study, we also, this is not exactly a confusion matrix, it's a co-occurrence matrix, but you can kind of get a sense too that the pattern here is somewhat similar between the neural network, which is here on the right, and the cardiologist, which is here on the left. So again, that's one of the interesting findings from our study. Now, the next study I'll talk about kind of uses not an end-to-end neural network approach, but a different pipeline that I won't go into too much detail here, but this was done in collaboration with Rahul Deo and Francesca Delling. But here, the reason I'm highlighting this is the ability to take a machine learning pipeline and predict some novel tasks, some new tasks beyond what we're used to using ECGs for. So the three, well, actually 4 diseases that we demonstrated this platform on in this paper in 2019 were pulmonary arterial hypertension, hypertrophic cardiomyopathy, and amyloid, as well as MVP as well, which I'll talk a little bit more shortly. Again, these were demonstration cases. So this type of setup can be used for almost any different task, and we've I'll talk about a few other examples of applications shortly to other diseases. But this was, in all these cases, one of the first demonstrations of machine learning for this kind of task. Again, taking in as input the raw ECG signal and predicting pulmonary hypertension, hypertrophic cardiomyopathy, and amyloid with fairly good discrimination. And for those who don't read ECGs regularly, it's worth mentioning that while there are associations of different ECG features with each one of these diseases that have been reported in the literature, we don't typically take an ECG in isolation and ask a cardiologist to diagnose pulmonary hypertension, HCM, or amyloid. Usually it's used in conjunction with other data points, but here using an ECG alone, these algorithms were able to discriminate these diseases from ECGs without these diseases fairly well. And since then, papers have come out that have sort of validated these initial demonstrations for each one of these diseases, pulmonary hypertension, hypertrophic cardiomyopathy, and for amyloid in different data sets. As I mentioned, that initial paper also examined mitral valve prolapse, which really formed the basis for our current collaboration. This is an R01 led by Francesca Delling. And here we're examining patients with mitral valve prolapse at risk for severe arrhythmia. And using a similar approach as shown before, we have trained a neural network to predict complex ventricular arrhythmia in patients with mitral valve prolapse from an input ECG that doesn't contain a PVC. So we excluded all the ECGs that had a PVC that might, have some PVC morphology that could predict CVE, complex ventricular ectomy. So we essentially had a baseline normal appearing ECG to the human eye and determined whether we could discriminate those patients with MVP that may or may not ultimately experience a complex ventricular arrhythmia. And so these are echo examples of mitral valve prolapse with some ECG associations associated with mitral valve prolapse, and then NSVT here on a Holter in this patient, and PVCs here in this patient. So ultimately, our algorithm was able to do quite well, again, with a normal ECG to predict future complex ventricular arrhythmia with an AUC of 0.81. And we also, in a subset of this cohort, were able to train an algorithm to predict late gadolinium enhancement as determined by cardiac MRI in patients with MVP. So this kind of straddles theme 1 and theme 2 of being able to not only process raw ECG data in fairly large amounts for this task, but also to do quite a bit more with the ECG than can typically be done. There are no sort of established ways to predict LGE, late gadolinium enhancement, on cardiac MR from an ECG alone. And so the AUC here was 0.75, not stellar, but certainly a signal to do so. Now, for each one of these diseases, we've kind of gone farther. So this is an example with pulmonary hypertension done in collaboration with some partners, some pharma partners at Janssen, as well as Mandar. And here we essentially trained a new neural network for pulmonary hypertension as diagnosed by right heart cath or echo criteria. So a much higher sort of bar of evidence than we had in the initial demonstration paper. And I won't spend too much time here, but the one thing I wanted to point out was the ability of the algorithm to not only discriminate all pH, but also precapillary pH, group 1 pH, and group 3 pH as demonstrated by right heart catheterization and electronic health record data. So we essentially showed that the algorithm did quite well to identify these different subgroups of pH as well. And this was presented at AHA this past year. The other interesting finding is when we took ECGs going back, this time 0 here is the date of diagnosis in the medical record of pH by right heart cath or echo. When we took ECGs going back up to 2 years and even 3 years, not shown on this graph, the algorithm was able to predict presence of pH. In this case, we can sort of interpret this as a presence of potential future pH, but in many of these cases, there might have indeed been pH that had gone undiagnosed so far in the medical system. And so discrimination was lower, but stayed quite high still, even for these ECGs 2 years before and even 3 years before the clinical diagnosis. And so this really opens the possibility to do large scale screening, potentially with ECGs to funnel people into the right channels sooner and potentially get them on treatment sooner. And so just to illustrate, these are some examples of ECGs, both from one patient at the time of pH diagnosis, as well as 24 months before the diagnosis. And the main thing that's being shown here is the fact that even at the time of diagnosis, we're not seeing huge abnormalities that tend to be associated with severe RV enlargement or pH, et cetera. There are especially the one 24 months before, there essentially looks fairly normal without which would have otherwise gone undiagnosed. But the algorithm is able to find patterns in here that is suggestive of pH. So I'll move on to the second theme now. And as I mentioned, a few of the examples that I discussed already kind of straddle the second theme of being able to do more with less. And I'm actually going to jump backwards and do a few of these other studies to illustrate how this was the case. So in this paper, 2019, we, in addition to training an algorithm for those individual diseases, we also essentially experimented to see whether we could predict echo measurements of structure and function with the ECG alone. So everyone knows, of course, that the ECG can be used to identify presence of left ventricular hypertrophy, LVH, with a slew of different criteria, right? So that's no surprise. But whether we could actually predict the left ventricular mass index as measured by an echocardiogram in grams per meter squared, so a continuous metric. So we're not only saying LV mass greater than X, we're saying LV mass is 75 grams per meter squared. We essentially trained a model to see whether we could do this. Now, this is a Bland-Altman plot, which essentially shows bias between predicted and true measurements. And there is indeed quite a bit of bias, especially in the low side and the high side. But there is, inarguably a signal to predict continuous LV mass index from an ECG input alone. And this was one of the first to show this. And of course, if we binarize it, the grams per meter squared and discriminate the left ventricular hypertrophy and not, we do pretty well as well. And so, but this is less of a surprise. Similarly, we showed this for mitral valve annular E prime, which is a marker, echo marker for diastolic dysfunction. Again, there's no established metrics by which to use ECG to use an ECG to identify mitral annular E prime, but we were able to predict this with some bias also, but clearly a signal. And so this really is the tip of the iceberg in our view in terms of what can potentially be done. And we have since applied this to various other sort of super ECG tasks to do more, again, to do more with less. The next example I'll talk about actually extends from this HCM disease demonstration from this paper in 2019. And this actually came out in JACC just last month. And this was a collaboration both with the folks at the Mayo Clinic as well as Myocardia, which just was acquired by Bristol Myers Squibb. And they, as many of you know, are the makers of mavacamten, which is the first-in-class small molecule for treatment of hypertrophic cardiomyopathy. And so in light of the initial demonstrations in the prior paper, we were interested to see whether, number one, we could take our trained algorithm for HCM and validate it in a clinical trial cohort of patients in the phase 2 Pioneer OLE clinical trial, just to see how our algorithm would do on external data. And secondly, to apply that over time in a clinical trial to see how the prediction score as risk for HCM might change over time. Now, I would point out that we were quite excited about this opportunity, in part because, as many of you know, clinical trial patients undergo a battery of studies in frequent order during the clinical trial. So they got Q4-week serum measurements, echo measurements, as well as ECG all lined up. And after 3 months, they got it every 3 months. And we had a median follow-up of about 6.5 years, so quite a large amount of follow-up. So the first thing we did, as I mentioned, was essentially validated that the algorithm that was trained in UCSF and was trained in Mayo separately performed well enough in the Pioneer cohort, and this was shown. And then we applied the data over the 216 ECGs acquired from the phase 2 13 patients over time here. And so on the left, on the blue, is the UCSF HCM score averaged across all the patients over time, and same thing for the Mayo score in red. And as you can see, as mavacamten was administered to these patients, the algorithm predicted decreasing risk of HCM in sort of a monotonic fashion here. And actually, it's not shown, but when the drug was removed, the scores shot up also in kind of a similar fashion as you might expect. And then here on the right, we're showing some echo and serum measurements also. So this is average LVOT gradient as well as NT-proBNP in patients, in these same patients. And similarly with mavacamten administration, the gradient as well as NT-proBNP, as you'd expect, goes down in a fashion that is faster than the score prediction, but follows a similar trend. And so this really then opens the possibilities of doing more with less, of using ECGs to decrease the amount of echo or serum measurements that might be needed to monitor patients on drug like this. Not only for HCM, of course, this is being shown for HCM, but potentially for other conditions as well. So this is the first demonstration of something like this, and I think opens the door to possibly doing this in clinical trials or even clinical settings. This is some of the raw data of individual patient trend lines for UCSF score, Mayo score, LVOT with Valsalva, NT-proBNP. And then here's the PK concentration of the drug, which, as you'd expect, came up stably and kind of really follows the trend. The score follows the trend of all of these. So I'll switch gears here and talk about another study which we deployed in patients with diabetes, which diabetes needs no introduction. what we strive to do here was determine whether we could take the raw signal of a PPG, photoplethysmography, captured from a smartphone by placing a finger over the smartphone and camera, to see whether we could discriminate people with and without diabetes. And I'll talk a little bit about the motivation here. Now, PPG as an introduction is familiar to everyone here, most in the format of oxygen saturation, and also heart rate from telemetry, but is also, of course, the technology that's used by Fitbits, Apple Watches, et cetera, to measure heart rate and also recently oxygen saturation. But we partnered with a company that makes an app that allows us to just measure a single wavelength PPG waveform by putting your finger over the smartphone. And their app initially was designed just to get heart rate, but we saw that we had this raw waveform. And a prior study had actually shown an association between heart rate and diabetes as measured from a smart device, from an Apple Watch, actually. And so ultimately, we were trying to validate that association, and we saw the raw PPG waveform data set that we had in Eureka Healthy Heart, and so this study was born. Now, there's a number of ways, as I mentioned, that have previously been used over decades to analyze the raw PPG waveform, and this is similar to the analogy I drew before, where the raw format simply couldn't be processed in traditional analytic techniques. And so we would derive metrics, right? So we derive the slope, the peak, the trough, the delta, right, of each one of these parts of the waveform, and then enter that into traditional models in order to try to predict certain things. In contrast, of course, we were able to take the raw waveform and analyze it with a neural network. Now, the literature has shown association with heart rate variability, autonomic dysfunction, endothelial dysfunction, and various aspects of the PPG signal, all of which, of course, are affected or related to diabetes. And so this was some of the motivation for why we sought to use this signal, and why this might have more signal than, for example, just the heart rate measurement that we initially saw the association from. So as I mentioned, we use a neural network to process this raw data, and ultimately showed that the algorithm worked fairly well on its own with the PPG signal. We had an AUC of 0.76. When you add fairly simple demographic metrics like age, gender, race, or BMI, the AUC improved to 0.83, which is actually, if you look at the comparative literature, is on par to many of the familiar tests that have been demonstrated, like pap smear, mammogram, have an AUC about this score in the literature. So we were sort of buoyed by the ability to do this with just the PPG as well as demographic measurements. And so again, the PPG alone is not typically used to diagnose or identify presence of diabetes, but this was an example of being able to do more with a lesser signal. So I'll spend just a little bit of time talking about the third theme. These are examples of ways in which we've applied AI explainability techniques to different types of data, with the aim of hoping to understand, number one, how the algorithm works, to make sure that it's sort of reliable, believable, and then this can be extended to try to understand more about physiology, mechanism, and what the algorithm is seeing in a data-driven manner. So going back to this JAMA Cardiology paper from last year, one of the things we did is we applied a technique called LIME, which essentially highlights, for a given algorithm, for example, for a given diagnosis. So for example, this is the inferior infarct diagnosis that was made by the algorithm for this ECG. We were able to identify what segment of the ECG provided the most value to this trained algorithm in order to make its inferior infarct diagnosis. And just as a reminder, we didn't tell, in training this algorithm, we didn't tell it that, for example, these are the inferior leads, that you might look for inferior infarct by looking for a Q wave in inferior leads, or reciprocal changes or anything like that. We simply provided, 1 million ECGs from UCSF from 2003 to 2018, and trained it to learn on its own from the raw data what would help it to identify inferior infarct. And so by applying Lyme here, we're able to identify what segments that the algorithm found were important to make this diagnosis on its own. And the intensity of the color correlates to the strength of the importance. And so as you can see here, and these are the only leads that are shown are the ones that had segments highlighted. The other leads did not have segments highlighted. So as you can see, the algorithm was highlighting, the QRS and Q waves here in lead 3 and inferior lead, as well as AVF as well. So kind of correlates with our understanding of how inferior infarct diagnosis tends to be made. And then we showed this similarly for other disease classes as well. So WPW, it really honed in on the delta wave. For RV hypertrophy, it honed in on the R prime here in V1. Left bundle, it honed in on the QRS here, et cetera. Now, it's not to say that every example that was shown sort of made sense to us, but what I would posit is that if there are sort of repeated demonstrations in a consistent manner across different cohorts of novel associations found with a given disease in this manner or other similar manners, that would then provide a basis for hypothesis generation for potentially future investigation as to why is this first part of the P wave being highlighted in this disease. We never thought of that to make sense to have anything to do with the atrium, but if demonstrated over time in a data-driven manner, this could then drive future investigations to investigate what the electrophysiologic, biologic implications of that are. So this begins to show the potential, I think, of using AI in this manner with AI explainability. In this paper, we also used a different technique, but similar kind of goal to highlight segments of the ECG associated with each one of these diseases, PH, HCM, amyloid. And again, a lot of them, for example, for PH, lead V1, the R prime was highlighted, which made sense to us, but there are some other segments that were identified, which didn't quite make sense. But again, if these are demonstrated over time repeatedly, then they might be worth further investigation for the underlying biology or associations. We've applied this to our LGE, our mitral valve prolapse, complex ventricular ectopy, as well as LGE algorithms as well, showing the different segments of the ST segment from V4, ST segment from V2, et cetera. And as I mentioned, there's various different kinds of explainability techniques that can be applied. So in our diabetes paper, we applied a different type of explainability investigation whereby we looked at the different filters of the algorithm and were able to sort of deduce from that investigation that things like heart rate and heart rate variability were largely captured by the raw data. And thereby the association was attenuated when we added that to the algorithm, suggesting that the raw data itself contained the elements of this that were important for the task. And similarly, that most of it, probably 70% of the data or so of the signal for detecting diabetes was actually contained in the R to R interval over time, and not the PPG morphology, although about 30% or so was contained within the PPG morphology. So explainability techniques help us to understand both how the algorithm functions, as well as potentially illustrating some biologic underpinning. Now, for the sake of time, I won't go into too much detail here. We've also trained algorithms, pipeline of algorithms for automated angiogram detection, angiogram analysis, with various algorithms performing detection, localization, and ultimately stenosis prediction, predicting the severity of a stenosis. This was done in collaboration with Robert Avram, who is, many of you know, was a postdoc here and found faculty in Canada, and presented at ACC last year. And focusing on the explainability aspects of this study, for example, we applied something called GradCam, which highlights the region of the image that the algorithm uses for its prediction. And so for localization tasks, we can see where the algorithm is focusing. And then this is a separate algorithm looking at trying to predict stenosis severity and using saliency maps, which pixels are the most important to predict the stenosis. And as you can see, the pixels of importance are highlighted here in white, and they're focused around the areas of stenosis here. So again, these types of explainability techniques can help us to understand elements of what the algorithm is focusing in on. And for the sake of time, I won't go too much into echo, but we've applied this to echo as well. For diseases of the right heart, for example, we can see the right heart, the right ventricle being highlighted. In other cases, for left ventricular abnormalities, the left ventricle is being highlighted. We've seen cases of the pulmonary artery being highlighted, et cetera. So we can sort of begin to learn in a large scale from AI techniques combined with AI explainability. So with that, I want to say thank you very much to various research mentors and collaborators that have assisted me and helped me over the past many years, without which I would definitely not be where we are today. I'd like to specifically highlight Josh Barrios, who is the lead data scientist in my lab, Robert Avram, who was a postdoc, many of you know, was here with us for several years, and Jeff Olgan for mentorship and support. Thank you very much for your attention, and welcome any questions.
Thank you, Dr. Tison. That was really great, very informative. I want to see if anyone has any questions. I would be really interested. I have very minimal experience in AI and machine learning, but hearing about a little bit about the considerations when you take into account, you mentioned earlier, noise or data degradation and quality check, especially when I think it's very interesting with the imaging modalities that new findings can be like hypothesis generating. So how do you do kind of like a quality check to ensure you aren't necessarily going and trying to act on something that isn't clinically significant?
Right. I think that's actually a great question. I think part of it, it has to do with finding the association repeatedly, consistently, and perhaps with, really trying to break it. That's what we say, like try to break that association and see whether we can poke holes in it, right? So doing it across different sites, doing it with different subcohorts and seeing whether it's repeatedly demonstrated. And then I think basic exploration of what's going on is important. I didn't talk about this for the sake of time, but this was sensitivity analysis using explainability, where we investigated the filters that were activating for a given PPG signal, this signal in particular. And you could see here that this orange arrow is a large artifact. It's not physiologic, and so is this blue arrow. And by doing this investigation, we could actually see that this particular filter here was honing in on this artifact. It's actually highlighting it's being activated in the setting of this artifact. And yet in later filters, it was ultimately being ignored. So it was being identified in order to ultimately be ignored. And so I think by doing this type of investigation, you could begin to see, okay, whether or not, this is a red herring, or, this is like a true signal, right? So I think but I think what you raise is a valuable reminder to sort of do our best to understand what is driving the findings we see.
Thank you. Any questions from the group?
Hi, this is Bill Grossman. Geoff, that was fantastic. And since you've got a little time, Ray Kurzweil, as I think you know his work, predicted long ago that the singularity is near, and between 2035 and 2045, AI was going to equal and then exceed human cognitive ability. And I have to say, I was very impressed with that when I first read it, and I thought, wow, that's happening. But my own sort of, I'm not watching this field as closely, obviously, as you are. My impression has been that it's coming awful slow in the last 5 years. Is it anywhere near achieving what Kurzweil was predicting, or was he off by 50 years?
Yeah, so I think, in my opinion, the short answer is no. And I think that, that this is opinion, but I think that falls into the hype cycle that wasn't really based in actual progress or understanding where things are. And I think where we are now, we're very far from that still. AI has become good at doing discrete tasks specifically. But we're far from sort of general intelligence, or there's a lot of quantum leaps that need to be made for us to get there. So I don't forecast that anytime soon, nor do I feel threatened, or do I think anyone here should feel threatened by AI. I think one of the analogies that I like the most that I've heard is that doctors who use AI may essentially surpass those who don't, right? So kind of like it's a tool, kind of like a flashlight. If you're investigating a dark room, that those people who are able to use the flashlight effectively can do their job better, can explore the room, whereas those who ignore it, think that it's it's hype or not useful, might be left in the dark, right? So I think that's the analogy that best describes where I think we are right now. That there will be applications that we're gonna see, in my opinion, soon. And those who sort of adopt it and kind of can integrate with it will be that much more enabled.
Thanks.
Thank you so much. Thank you everyone for joining us. We're at the hour, so I will let you go, and we'll see you guys next week. We have Dr. Jorge Kaiser. Thank you again, Geoff.
Thank you.